Hello, and welcome to the Internal and External Transducing 6-Minute Synapse series. In this session, Internal and External Transducing, we will cover the differences between the two methods of measuring ICP, including the benefits and drawbacks of using both types of transducers when monitoring intracranial pressure. My name is Kenna Seal, and I'm a neuroscience nurse and clinical specialist at Natus. If I had to guess, I would imagine that most nurses at the bedside taking care of neuromonitored patients probably haven't given a lot of thought to what type of transducer it is that they're using to get the ICP, intracranial pressure, or waveform information. Most of what we really want to know is how accurate and reliable the information we're receiving really is. So let's talk about that a little bit. Let's start with internal transducers. These transducers are typically found at the tip of the catheter and monitor from inside the cranium. When you think internal transducer, think inside the cranium. These catheters can be placed in many different spaces. You can be using a catheter that sits in the ventricle, the tissue of the brain or parenchyma, the subdural space, or even the subarachnoid or epidural spaces. Anytime you're using a monitor such as the Camino ICP monitor, you're using an internal transducer. These catheters or transducers are only zeroed one time prior to insertion and have a minimal drift over days instead of hours. The intracranial pressure and waveform are accurate no matter where the monitor is in relationship to your patient, meaning the monitor can be on an IV pole, bedside table, or in the patient bed during transport, and the information you are seeing on the monitor is true. Using an internal transducer provides you with consistently accurate information, but also provides you with continuous ICP and waveform information. And if you're using a catheter that sits in the ventricle, such as the flex catheter pictured in this slide, then you have the ability to see your ICP and waveform while you are open to drain, which means you never risk missing an event such as a spike or elevated ICP while you're open to drain for the hour. Conversely, external transducers only provide ICP and waveform information when the drain is clamped to the burette of the external ventricular drain. Now let's shift gears a little bit and talk about external transducers. When you think about external transducers, I want you to think of it as monitoring or gathering its information from outside the body. These transducers are strain gauge and fluid filled. They are reliant on what we call an active fluid column to be functioning. Now, what does that really mean? That means if your drain is not patent, if you cannot drip CSF into the burette of your drain, then all of the information you are receiving from the transducer is completely inaccurate. This is why, as soon as your drain is not patent, you need to notify your provider, because you are no longer gaining any information in regards to your patient's intracranial pressure or waveform from that transducer. External transducers also have a drift that occurs over hours instead of days. I know you've now heard me say the word drift over and over again, and you may be asking yourself, what is this lady talking about when she says drift? When you think about drift, I want you to think about your transducer slowly becoming inaccurate. Because external transducers drift more quickly, meaning over hours instead of days, we have to re-zero them often to maintain accuracy. The same applies to patient positioning. You must always maintain the drain at the level of the foramen Monroe using whatever external landmark your facility has chosen. If you sit your patient up, your drain moves up. You lay your patient down, your drain moves down. Anytime your patient moves, you have to re-level your drain to ensure the accuracy of the ICP information. External transducers are the type of transducer that you will see the most often because drains are the most common way of monitoring or treating elevated ICP. There are a few other things that affect the accuracy of the information you get when using an external transducer. The height of the drain, meaning the level to the foramen Monroe. If it is not level, it can cause a false high or low ICP and also result in over or under drainage of CSF. Any bubbles, blood, or tissue in the tubing or transducer itself can cause a dampened waveform. And a loose connection of the lure between the drain and the transducer itself can also cause a dampened waveform and ICP inaccuracy. There has been a recent study done out of Hennepin County Medical Center in Minneapolis on the differences in accuracy between the two types of transducers. Over 500 hours and 33 million data points were captured on severe TBI patients with both internal and external transducers. The data showed that the external transducers were more likely to be inaccurate and falsely elevated, resulting in potentially treating a patient that wouldn't need treatment. This inaccuracy was attributed to the nursing management of the drain. These drains require constant releveling and frequent re-zeroing, and because these patients are typically paired in the ICU and nurses are extremely busy, it is impossible to ensure complete accuracy at all times. In conclusion, there are distinct differences between internal and external transducing. Nursing management of an internal transducer will consist mostly of ensuring that the catheter stays in place throughout the course of treatment. An external transducer's accuracy is critically dependent on the nurse management, keeping the drain leveled consistently and zeroing frequently. It is good practice to re-zero the external transducer before treating an elevated ICP, ensuring that the number you are treating is correct. Here is a list of my references. Thank you for joining this presentation. If you have any questions or comments, please feel free to reach out to me at kenna.seal@natus.com.